And my name is Arla Dunlop, and I'm the Staff Development Director here at Kittitas Valley Healthcare. And I want to welcome Dr. Aleks Tkach. He is a neurologist from Virginia Mason. And then also Melinda Carter, who's here, and she is a nurse practitioner also in the neurology practice there at Virginia Mason and the stroke coordinator for Virginia Mason. And then later this afternoon, Wendy Wank will be joining us for our end-of-life panel discussion that we will be conducting between 12:30 and 1:30. So those of you that are here for stroke that want to stay on, we would appreciate that and welcome you to do so. So I just want to start off with a little bit of history of our ECS system here at Kittitas Valley Healthcare. We have just recently recategorized, filled out our application. So we are good now for another 3 years. And we are part of the ECS system, which stands for Emergency Cardiac and Stroke System. It's a designation from the Department of Health. And we voluntarily participate in that. And the idea with this is to get the patients to the right place to get the treatment that they need. So if you look down below, getting the right patient to the right place in the right amount of time to save lives and reduce disability. So we have stroke, heart attack, and cardiac arrest. And Virginia Mason is our partners for our stroke, and we just implemented our new telehealth program, and we'll probably talk a little bit about that today during their presentations. And you see us right here, here's KVH. There's certain criteria that we have to achieve to be part of this ECS designation as a level 2 stroke center, and then treating hospital would be, for strokes, most of the time Virginia Mason for us. So here's just kind of some of the highlights on our categorization for being a level 2 stroke center. Like I said, we were recategorized in September 2014, and that is in effect for 3 years. David Frick is our stroke medical director here, and then Linda Wickers is our RN stroke coordinator. And those are both requirements that we have that. We also have to have a core team of stroke providers, and then our actual care team, which is the frontline staff. Those of you that work in the emergency department, med-surg, CCU, our emergency room physicians are part of that care team. We need to have that stroke team available 24/7 within 15 minutes, a neurologist available 24/7 within 20 minutes. And the way we achieve that, since we do not have any neurologists that work here at KVH, we have our telemedicine. And so we can call up, get on the telestroke video camera and do a conference with our neurologist partners over at Virginia Mason. We also have to have CT MRI 24/7 completed and read within 45 minutes. And then IV thrombolytic therapy 24/7. There's more criteria that has to be met every 3 years, and part of that's education, so that's why we're here today, and we're very thankful for our partners to come over here and present for us. Those on the core team need 8 hours of stroke education. Those on the care team, so all of you, need 4 hours of stroke education every year. And on our odd years here at KVH, we do the NIH stroke scale, so you'll see that coming back up in 2015. And our even years is when we do more of a comprehensive stroke education consisting of approximately 4 hours. So this year we had our telestroke that we went live with back in October. And so you'll get a few hours from that, and then this will be about 3 hours. So we're getting plenty of education to meet that 4-hour requirement that's required for our designation as a level 2 stroke center. Some great resources if you want to know more about stroke, and we also have an obligation to reach out to our public, to our patients, and teach them about stroke. I'm sure you've heard about the FAST campaign, and we're going to be talking about that a little later on. But we really need to teach the public what to do if their loved one or if themselves is having a stroke, and where they need to go so that they can get cared for in a timely manner and hopefully save some brain cells. So we do have handouts if you are interested. All of these links will be available there, and we are videotaping too, so that we can present this education to those that can't make it, or if you want to reference it at a later time. So I'm going to go ahead and turn the microphone over to Dr. Aleks Tkach, and he's going to talk to you a little bit about TIA.
So I'm Aleks Tkach. I'm one of the stroke doctors over at Virginia Mason. I trained at the University of Washington residency, then I was down at Banner Good Samaritan in Phoenix for a while. It's a pretty busy place. And then I did vascular fellowship at the University of Utah. And one of the main reasons I wanted to do fellowship there is because they have an amazing telestroke network. So they have hospitals that are by air 4 to 5 hours away. And those people are giving door-to-needle TPA in less than an hour pretty much every time. Their door-to-needle times are like 30 minutes, 30, 40 minutes. And they see 3 to 5 strokes a year, and their ER is really more of a clinic. It's usually 1 to 2 bed ER with a CT scanner. So that's why I wanted to go there, is how do you achieve that? Because most of America has that sort of distribution. And so this is part of what I've always liked to do, is to kind of talk and educate. And one of the biggest reasons I like doing this is that in a smaller community, the impact that you all have is much greater. And whether that be just the care you provide here or the influence you have, because chances are people in your community know somebody who's related to this hospital in some manner, correct? And so you have this unique opportunity to educate on a much more impactful manner than I can in, say, all of Seattle, right? And so you can really make huge differences not only in your care in the hospital, but outside as well. So just curiosity, show of hands, who's nursing? Who's ER? Okay, good. And pharmacy? Any physicians? Okay, great. What? Excellent, wonderful, good. So I'm going to talk about transient ischemic attack, and the way this works best in these situations is if you guys stop me and ask questions and things like that. I might say I'm going to get to that in another slide, but I'd really like to focus this for your education as much as possible. I can listen to myself talk anytime. So just to kind of put these into scale, quite a few transient ischemic attacks every year. So much so that it makes up 2.3% of the population, about 5 million a year. The big thing is a big chunk of those folks are going to go on to have an actual permanent neurological deficit, which they then will have some amount of recovery from. And most of those are going to be in the first few days after their transient ischemic attack. So in the first 24 hours, it's also a big thing. To put in perspective, you guys have been probably used to ACS sort of syndromes for a while, right? And a lot of acute stroke management has actually been following on the heels of acute cardiac management. To put this in perspective, somebody who comes, that's much higher. That's twice the risk of MI with somebody who presents with an ACS syndrome. So TIA really is sort of a big red flag for somebody about to have a big stroke. The other thing too is always remember that actually it usually doesn't come out of the blue. Good half of those folks are going to have symptoms that prior week. The other thing to take home from today is that there's a lot of things we can do to reduce those chances, huge amounts of reduction. The definition of transient ischemic attack has changed in the last couple of years, and that's something that always confuses people. We used to say that the symptoms didn't last more than 24 hours. That was the definition. We've moved now onto a tissue definition. So basically with imaging or somewhat clinically, you have no permanent damage. And that's sort of the idea. Anywhere in the CNS sort of thing, so brain, spinal cord, eyes really qualify for that, okay? And the reason why is that when, under the previous definition, once we started MRIing everybody, we found that over a third of those people actually had damage on their brain or eye or something like that, which is really the definition. So actual stroke, you've got damage we can see. Transient ischemic attack, we say, no, it sounds like a blood vessel was occluded, but you got better, and we don't see damage on imaging or looking at the retina, okay? Little definitional changes that have happened in the last couple of years. So let's start with the case. So an 82-year-old gentleman with a history of coronary artery disease, diabetes, hypertension, smoking. Sounds familiar, right? Pretty typical for most of America. 20 minutes of trouble using his right side of his body and trouble talking. Blood pressure was elevated, his heart rate was fine, but irregular. His blood sugar was mildly elevated, but probably not enough. So he gets a head CT. Didn't look like there's really anything wrong on that, probably a little volume loss. But then kind of what do you do now, right? So you guys are used to this ABCD2 score, correct? You guys familiar with this? So this is a scoring system where you look at these some highlights where people have found that this sort of predicts going on to having a stroke, having a permanent deficit, and you're trying to avoid that. So A for age, B for blood pressure, C for clinical, and D for duration and diabetes. That's the two Ds, okay? So use this point system. It's been validated across a couple different measures, both in North America and in Europe. And so this is a sort of breakdown. You might have seen this graph before. But essentially, we consider 0 to 3 sort of low risk. This is the percent stroke in the next different columns, 2 days, 7 days, 30 days, 90 days. We consider 4 and 5 sort of moderate risk, and 6, 7 high risk. So this is a sort of 5% mark. So we consider at the 4, your risk gets up to about 4% in the next couple of days. And those are the folks who tend to admit. Okay, so that's what you kind of really need to remember from the ABCD score. 4 or more, you're going to want to admit or get rapid evaluations to try and reduce stroke. Less than that, so 3 or less, is probably low enough that that can be done as an outpatient, but probably still should be evaluated. So that's just sort of summary of that. So his score was 6, probably should be worked up quickly and admitted. But what do you think? So let's go back to his case. So he had transient right-sided weakness and trouble talking. Anybody know sort of idea of, in this particular gentleman, what would have caused this to get better? And he got better, I'm sorry. What would have caused it?
Atrial failure, but he
Yeah.
broke down that whole.
Great. So cardiac embolization related to atrial fibrillation, good. He's a smoker, he's 82. So carotid disease is also really high on the list. But the idea is that some clot went up into the left middle cerebral artery, cut off blood flow transiently. And he was lucky enough that it recanalized fast enough that he didn't end up with permanent damage. But that means he could have a clot sitting in his heart that he could benefit from anticoagulation. It means he could have a ruptured plaque in his neck that could benefit from treatment. And we'll get into it that really all of those are important. So a little bit more work has been done on this, and we'll get to that in a little bit. So how about this guy? This guy kind of points out more of where this gets a little bit more mucky. So that first one's pretty easy, right? He looks like a high-risk guy. His symptoms are pretty bad, so probably get a pretty good workup pretty quickly. This is a little bit different, though. This is a younger person, 45, does have hypertension, diabetes, smoking, and obesity. So again, not an uncommon scenario, but just a lot younger, right? 7 minutes of trouble talking rather than the more prolonged we had. Maybe some confusion, maybe some right-sided facial droop and right-sided weakness as well. Blood pressure is elevated, but not too high. His heart rate's fine and regular. CT looked fine. So his ABCD2 score is only 3. So we say, well, 3, that's sort of lower than 4. Maybe just go home and get that worked up as an outpatient, right? Because he's 45 too. 45-year-olds don't usually have stroke, right? Well, this guy actually turns out he's got left ventral carotid stenosis about 80%, and his MRI actually has a subacute stroke. So he actually had a small stroke. So in the previous classification, he might have gone home and we said nothing, but now we have some other sort of evidence. This is the kind of stuff we're looking for in neurology. What are some of the smoking guns we really sort of increase our stroke risk rate? The other thing too is this isn't the first time he's had this. So with similar symptoms over a previous couple of days, we think about an active lesion wherever it is, right? It's continuing to throw off clots, continuing to put him at risk. So what's been added to the ABCD2 is a couple other things, ABCD3 and this I score. The nuts and bolts of this isn't as important. The point is we think through where these things come from and how we best go about reducing those risks in the future. But this is a nice validated study again where they added those sorts of things. So they added, have you had previous symptoms? That's the 3, and they have add a couple more points to that and have a little bit slightly different number, but same sort of a tertiary, breaking things up into thirds. And the I is imaging, so that means that you have a stroke at any age on your imaging, or a high carotid stenosis. So those are the two things. And then we get a much bigger, so this is sort of your risk in the days based on those low, medium, and high. low, medium, high, low, medium, high. And what happens when you add sort of that more specific criteria with A, B, C, D, 3, and I? So if you add stuttering sort of things, so multiple events, and imaging, and you really see that this high risk group really starts to jump out. So he turns out that if you add the stuttering, he gets a 5. So that bumps him up into sort of this middle category, which is before we would have said he would have been kind of, low risk, a couple percentages. Now he's really much more up into that 6% or so. Or sorry, 8% in the first week, 13% in 90 days. And if you add the imaging, he's actually high risk. So he's actually much more in here. So he's over in the teens for a stroke in the first week. And this is the kind of stuff that we've been advancing since ABCD2 came out to try and understand this. Now it goes the other way too. So this is a much more sort of real world study. So it's, it's nice when you're in a place that you can go and get all that imaging and get all that done quickly. But Canada tried to do another little take on this a couple years ago, and they did a very nice prospective study. So what they did is we said they know what ABCD2 is. Let's do workup on pretty much everybody, and let's chart a whole lot of stuff and see what shakes out. So they came up with a whole lot of things. I'm not going to kind of belabor all those little things. They came up with some interesting things. So not only did they look for age and blood pressure and the other ABCD2 stuff, but they looked at all past medical stuff. They looked at labs and all this sort of stuff. And a couple, oh, that's not good. I don't know how that happened. But anyway, it's diastolic blood pressure over 100. What they found was some pretty interesting things. So the same idea, the stuttering kind of makes you a little bit more worried, but here are some other things you might not have thought about, which also makes you a little bit worried. So if you're already taking aspirin, that's a bad sign. It's either not working or it's breaking through that and it's a high risk lesion. So that was kind of interesting. If you've ever had an infarct on your head CT, whether it's new or old, that puts you at a much higher risk. Diastolic blood pressure over 100, which is interesting because a lot of us don't think about isolated diastolic hypertension as a major risk. We usually think of systolic and things like that. Obviously, dysarthria aphasia, that was nothing new. Atrial fib and flutter, that wasn't anything new. First transient ischemic attack lasting longer is supposed to be 30, or a folder and something else, I don't know. First and lasting over 30 really seemed to get out of there. Trouble walking, unilateral. Platelets over 500 jumped out. The other thing too that was nice, again, because this is sort of a real world sort of idea, how as an ER physician do I work through these, what actually matters to me when I see them? Turns out isolated vertigo reduces your chance of it being a stroke by quite a bit. Yeah, right? Kind of useful. Not that I haven't seen isolated vertigo as a stroke, but it's just very uncommon. So this is their scoring system. I'm not going to belabor that, but this is their breakdown in points. So you can actually have a negative score, and that's pretty remarkable. You could also have a very high score. Their highest score that they could get to clinically was really 12. So the take-home points is that brief, lightheaded, and vertigo basically negative. You're actually less likely to have a stroke than something else. And then the things I already covered about already having something on the CT, having elevated platelets, things we already knew about atrial fibrillation already on aspirin I thought was interesting, platelets being high, and gait disturbance really kind of jumped out as new things. So that was kind of a nice study. The way I like to think about and try and conceptualize. So the recommendation is hospitalization over ABCD204, and that's because we can get all this other imaging done and try and even further risk stratify and treat people, and we can really reduce the risk of stroke. It actually turns out that seeing less than 4 in clinic and admitting over 4 actually saves money, and that's actually been validated in a couple different models. This is just one of them. That when you have a stroke and are disabled, that's fairly costly. Because people typically don't die from their strokes, they're just disabled. And so when you think about putting in that perspective, again, we kind of usually think about with heart disease. So if you have a bad heart attack, you're not disabled, you're dead, right? So that actually has a different financial impact than needing to be taken care of for 24/7 for the next 10 years. So what do we do? Well, first thing we do, everybody does is get a head CT. Again, it turns out that about almost 20% of people are going to have an old infarct. That number goes up, of course, with diabetes and age and things like that. But again, that alone says, well, you've already had an old one, whether you realize it or not. That actually puts you at much higher risk to have a future one. We look at the pattern, and I'll get to this in just a second in terms of the anatomy and trying to figure out what caused it. in order to try and reduce these in the future. And we look at the burden of disease as well. So people who have had a lot of strokes, guess what? They have more strokes, and that actually can be harder to treat as well. So this is a normal head CT for those of you who are not familiar looking at head CTs. Left and right is always reversed. Front is always, the nose is up at the top, back down here, and they're axial slices. They're going up and down like that. This is sort of what we call sort of a middle, this is basal ganglia sort of region. So this is kind of nice because this is the area where strokes from high blood pressure happen, and then out at the cortex is usually things where clots. This didn't project too well. You're supposed to be able to see there's a little dark spot here. So that's a lacoon. So lacoons are the kind of things we see. They're small. They come from things like hypertension. Oh no. So sad. There's supposed to be a picture there. Maybe for the next talk we can figure it out. So that picture was an angiogram. And the nice thing about the angiogram is it demonstrates the anatomy of the blood vessels in the brain because they're different than anywhere else in the body. So the kind of deeper structures in the brain, sort of away from the cortex, the deep south, the basal ganglia, a lot of the brain stem, they're supplied by blood vessels that are unlike anywhere else in the body. They're very, very, very small, and they run in parallel. So rather than branching and branching and branching like a tree branch, they don't do that. They're kind of like this, and they're extremely small, and they come right off of large blood vessels. So they have to take systemic blood pressure levels, but they do not have a vessel wall that can handle that. Hence, blood pressure is by far the #1 risk factor for stroke. So those are what damage. Not only when they have to endure blood pressure over years, they get this sort of scarring, lipohyalunosis, that narrows the blood vessel. So one day a blood cell can't get through, you get a stroke. They also are fragile and rupture. That's also where most of the hemorrhages occur as well. So that's good to know. So those sorts of areas like this lacoon, that is age, hypertension more than anything, diabetes, smoking, anything that you think causes microvascular disease, it's going to hammer that area most. And in this country, it makes up the majority of strokes. When you get into an older age group, atrial fibrillation kind of starts coming up higher. But as diabetes and hypertension also increase your chances of atrial fibrillation, it gets sort of a wash as we get older as well. The other thing that with the angiogram to look at is sort of this branching points that come out here, and that's where we see these embolic strokes. So you get sort of wedge-like infarcts, and I actually have a CT and MRI of that coming up. Or no, I do, yeah. And that's when we think of clots coming up from somewhere else and lodging somewhere in the brain, or just hypercoagulable states. Good. So you can imagine that. That's what it looked like. So what about DWI? So MRIs. So we also get MRIs in a lot of our transient ischemic attacks, again, because we look at the pattern. So if we say, oh, that's a lacoon, it probably isn't from your heart. Could be, but it probably isn't. And things like blood pressure management are pretty paramount. They're good for everything, but in particular, things like lacoons. And then a number of studies have looked at just if you find a slightly positive DWI lesion, so a positive DWI lesion means like it's a fresh stroke. That's what you need to know about that. So if you find a fresh stroke, even though the symptoms got better, the chances of having recurrent strokes are much higher. And what's interesting about that is about 20% of that was in the hospital, those follow-up strokes, when they were hospitalized for the transient ischemic attack. So to kind of put in perspective, that same head CT that I said was normal, that was actually a patient who got TPA. Here's his MRI. So this is a bright DWI lesion. So he actually has a stroke. That's permanent damage. The TPA will help him recover from that, and this will get smaller, but that head CT, before we gave him TPA, looks fine, right? And his symptoms actually, by the time we gave him TPA, were already resolving. We gave it to him anyway, because we thought he looked kind of bad. And a little note about TPA, there's this sort of notion of not giving TPA to rapidly resolving, and that's kind of falling away from the guidelines. There's also a notion of not giving TPA for low stroke scales or minor symptoms, but those are both very subjective, which is why we're kind of giving them away. About a third of people with rapid resolving symptoms or low stroke scales will go on to be highly disabled in the next 3 months. So and the smaller the stroke, the less likely bleeding risk. So we're kind of making a turn with this towards being more aggressive with TPA. There's currently a study actually randomizing these folks right now, looking exactly at that. But this guy had trouble moving one side of his body. It would have been hard for him to walk around. So even though he was getting better, if we said, well, your symptoms stay just like that, you're going to be disabled. Let's give you TPA. And that was his MRI. LINQ-ish, I guess you'd say. It's a little bit big for LINQ. So another one that's fairly subtle for somebody who looks at CAT scans a lot, it's not very subtle, but for people who don't, one of the things that's come up is, not to say radiologists, not to be down on radiologists, but neuroradiology, like anything, is its own study. And this is something I've seen missed many times. They're just not used to looking at CTs as much as some other folks. So this is actually initially read as possible stroke. And I'll show you the MRI here in just a second. But to me, it's pretty obvious. So this does not look anything like this. It's very hard to see how things are projected on this. But this is actually an evolving large stroke on this side. This is actually so already complete, I actually probably wouldn't give this person TPA because this tissue is probably already dead. And you're just going to reperfuse dead tissue, which is going to bleed even more with TPA. And that's his MRI. So that's already been out. Okay?
So when are you doing the MRIs?
So the MRIs are usually done in the first 24, 48 hours. It really depends on the patient. There's not really a rule for emergency MRIs. I have done that. I've worked in areas where I can get MRIs in 20, 15, 20 minutes. They usually take another 20, 30 minutes to get done. So that should never delay the use of TPA. But there's plenty of times where I start TPA and then I put somebody in an MRI scanner to kind of further quantify sort of things to see. They're usually when the diagnosis isn't clear. That's when I usually use that as an emergency. Otherwise, they can wait days because it's not going to change management.
I think I missed it. Well, what's DWI?
So DWI, what you need to know is that means it's an acute stroke. If the DWI, if you see this bright spot on DWI, we can talk about MRIs if you want, but it's kind of out of the scope of this. But basically, if the DWI is bright, you've had an acute stroke. If it's called diffusion restriction. Yeah, okay.
And that's ischemic you're talking about?
Yes, that is ischemic. Good question. So this is a wedge, like I was talking about. And this gentleman had atrial fibrillation. So what else do we do? You guys probably seen a lot of carotid ultrasounds. So again, we're looking for sources. So this guy, he should have a carotid ultrasound. At the time when he had this, he didn't have known atrial fibrillation. So he gets a carotid ultrasound and we look for stenosis. Generally over 70% on the same side usually kind of is one of the cutoff for doing something like surgery or a stent. Some people use 50% and sort of if the lesion looks really sort of like there's a clot sort of flapping in the breeze sort of look to it, you might go do something about that. And that's to reduce further strokes as well. Now the sensitivity and specificity of carotid ultrasound is not perfect, but it is very fast, it's very easy, it's pretty safe, right? There's no radiation, there's no contrast. Almost everywhere can do it quickly, so it's very nice. But there's a lot of drawbacks on both sensitivity and specificity. So you would think the specificity would be higher. You'd think if you saw narrowing, then it's probably true narrowing. It turns out that's wrong. It bases on most of it's based on blood velocity. And so if you're really scared because you just had a stroke, your cardiac output is higher, or if you just have brain damage, your cardiac output is higher, your velocity is higher, so it can be falsely high. If the other side is stenotic and you're putting most of your blood flow through that one side, that's going to be higher as well. And there's also falsely low, falsely reassuring ones as well. So it's not perfect, but we found a good correlation anyway with stenosis being at much higher risk for stroke in the next 90 days. And it really drops off actually quite quickly. So it's 90 days, but it really starts dropping off over the first 3 to 6 weeks, that sort of time frame. So if you're going to do something about it, that's the time, meaning surgery or stenting, that's the time to do it. Similarly with CTA, so a CAT scan angiogram, so we have to give them radiation and contrast, but the sensitivity and specificity is much higher. This also we can see all the blood vessel. So the problem with ultrasound is you can't really get behind the angle of the jaw. And so if you get up, you can't get into the head very well with it either. So this gives us everything. It also doesn't have that problem of velocity. So we get a little more use out of that. We can also see sort of what this thing looks like. So if it's smooth and calcified, that's probably not a high lesion. But if it's very hypodense, meaning it's just a soft plaque, and it looks like it actually has a piece just kind of floating in the lumen, that's probably pretty bad. So those are the things we look at. We see intracranial stenosis as well. So sometimes these strokes are actually just narrowing of blood vessels in the brain from things like smoking, diabetes. And they just got sick and had a little bit low blood pressure. That's a very different thing than having an embolization to the brain. MRA is even better. MRA is, of course, the hardest, or harder to get. Can't get it if you have a pacer or claustrophobia. You have to be pretty still for an MRA, even more still than MRI for the brain. So that's that. So it's also very useful, but a little bit harder to get. And then the gold standard is a cerebral angiogram. So this is a catheter-based angiogram. Usually goes in the femoral artery, shoot dye up into the brain. We can see the smallest blood vessels. We also get a real-time idea of what the flow dynamics look like. So we might see a high-grade stenosis on one side, but it turns out there's basically no blood going through that. So it's probably not likely to cause more problems because there's nothing going through there. So therefore, surgery or intervention actually might be more harm than good. So that's the best, but it requires an invasive procedure at the same time. On the bedside, we can actually stent at the same time as well, take care of it. So on the good side, the ultrasounds are easy and fast and cheap. The CTA has better resolution, and it's also very fast. It's really good for severe narrowing. MRA has no radiation. You can actually do it without contrast at all, so if people have renal problems. And you can actually look for plaque hemorrhage and rupture. You actually look for a little bit of blood flow and enhancement in the plaque itself, which actually is much more likely to have a stroke, even with only like a 20-30% narrowing. People have a plaque rupture look like they're at just as high increased risk as stenosis, high stenosis. And the conventional gives us the best results overall, but the drawbacks are not as sensitive. You got to have radiation and contrast with the CTA. The MRA can overestimate. It also is somewhat based on flow dynamics, so it can actually overestimate lesions. And obviously, it's expensive. It's limited. And similar with the cerebral angiogram, it's expensive and limited, most invasive. You actually cause strokes with cerebral angiograms as well. So that's sort of how we think through these different modalities. Does that make sense? So what about the echocardiogram? So folks who don't have much of a cardiac history, it's not super useful. So, or any cardiac risk factors, it's not super useful. Now, it's a bit of art to figure out who that is. So for instance, if I had a 27-year-old athlete, most likely I would think the echo is pretty low yield. But then again, 27-year-old athletes don't get strokes that much. So maybe it is something you want to look at. So that's what I mean by it's a bit of each. On the opposite side of that, let's say we have that first patient, 83-year-old person with atrial fibrillation, probably going to get anticoagulated anyway. Why look at their heart? It's probably not going to change management. So unless in that patient, I probably wouldn't get an echocardiogram unless there was something else going on with the heart that I really wanted to know about, like a aortic stenosis or something like that. So something unrelated. So, but it does turn out that if you're a smoker or diabetic who's 70 and maybe you've got some edema, yeah, actually then the ultrasounds turn out to be very useful. Okay. The things we're looking at are a couple of things. One is just a source. So it turns out if you have a heart apex, the left apex, just not moving at all, clots can form there. That's useful information. If you have a clot in the left ventricle, that's useful, but that's pretty rare. One of the big things I look for is left atrial dilation, or other things that really associate or increase your chance of atrial fibrillation. Everybody knows I'm talking about atrial fibrillation, right? Okay, good. Just making sure. Not trying to be insulting. So that falls into that 61% category. So if somebody had left atrial dilation, that helps to know that. Because it might be your first stroke, but if you have a dilated left atrium and you're 70, I'm probably going to empirically anticoagulate you even if I don't find atrial fibrillation while you're in the hospital. We'll look for it later. That's how it changes management for me. And then we get towards the EKG, Holter, and other things. So the idea, again, we're looking for cardiac arrhythmias that lead towards a higher risk of atrial fibrillation that's not significantly reduced with standard stuff like aspirin. You have to use anticoagulation, and we have a couple of choices now. And how much do you look for it? How much do you try and track that down? And again, it kind of matters on the patient, because if you're not really an anticoagulation candidate, doesn't really matter too much, right? So if you're 88 with metastatic cancer, the benefit of anticoagulation is probably not too high. That's probably not somebody you even really need to track that down on. Or if you're 88, you live way up in the hills north of here, anticoagulation might be really dangerous because you say, I'm not going to stop riding my horse or four-wheeler, and I'm not going to get my INR check. So maybe I just don't take anticoagulation anyway, knowing that if I did have atrial fibrillation, I'd be at risk for stroke. That's all it is. So you kind of have to think those out in advance before you start figuring out how far you're going to look. So EKG and telemetry while somebody's in the hospital is very useful. It's fairly low yield. Holter monitor is sort of a similar sort of setup that you wear around for 24, 48 hours. It just kind of records the whole time. Also adds a couple percentage points for yield. Up until recently, we use a lot of outpatient cardiac telemetry monitoring, which is a couple pads usually, a couple adhesive pads in a box. And that box kind of always monitors and then records and broadcasts if there's something that happens, so they're event monitors. But we have a new loop recorder that just came on the market about 6 months ago. It's been in testing for 5 years. It's about half the size of a USB drive, and it goes under the skin, so it's a small incision, too small to require a stitch. So it's a very simple procedure. These, about a third of patients can't tolerate these because of the adhesive pads. So especially guys with chest hair can't sleep with it because every time they move it, pulls their chest hair, wakes them up. So those, I've also had people that have actually been horribly scarred from reactions to the adhesive pads. So those are not so happy. And the sensitivity is not as good. So these are great. The higher sensitivity, the battery is guaranteed for 3 years. So even if you don't find atrial fibrillation, you can find lots of other stuff that's useful. If you have atrial fibrillation, your cardiologist can actually help tailor the medications to try and reduce that if you're symptomatic. So they have a lot of other utility. They're MRI compatible. And it's a one-time cost. And it just reads, it should download every night to a little box that broadcasts cellularly. But otherwise you can hold it up to that box and it'll download and broadcast. So I have a really low threshold for these. The only people who don't want these are people who don't like the idea of having an implant in them. But most people, when we kind of go through all the information you get out of them, they say, oh, that's actually really kind of cool. I kind of want one of those. For women, I usually cannot feel them very easily on exam in about 3 or 4 weeks. So if you have any sort of breast tissue, you basically can't find them. They're very difficult to find. So there's not a cosmetic problem with them. Unlike the old loop recorders, I don't know if you guys saw those. They're kind of like pacer boxes. So they're actually pretty big and bulky. So that's something new that you might see coming for folks that are coming back from Virginia Mason. Again, with any of these, we just consider whether finding things will change management. To other basic stuff, everybody usually gets a fasting lipid panel. We look at their sugars. I look at iron studies. This is not a recommendation, but it probably will be soon. So it turns out iron deficiency anemia is the #1 cause of stroke in babies, in neonates. So when they're making that transition from milk, from breast milk to bottle, and they have a stroke, that's by far the #1 risk factor is iron deficiency, and that prompted other coagulation studies. And it turns out, guess who gets iron deficient? That's your 70 or 80-year-olds. They usually have sort of chronic iron deficiency anemia from either chronic GI bleeds or other issues. You would want to know about it and treat it anyway, right? Because of all the other health risks that come along with iron deficiency anemia. But you don't usually think about it as a procoagulant state, and it is. And it's very easy to treat. It turns out treating it reverses the procoagulant states too. Plus, you'd probably work them up for, colon cancer if you found it as well. So it's actually a useful thing, and it's actually pretty cheap and easy to do. Hypercoagulable workup is pretty low yield unless you're pretty young and have no other risk factors. And even then, it's only about a 13% yield, and it's fairly expensive. It takes a while to come back. So unless you have somebody with recurrent DVTs or unexplained and things like that, which you'd probably just be anticoagulating anyway, I wouldn't really. This is not. I don't order them very much. I guess what I'm saying. It comes up a lot. People like to order it. It's rarely useful. It's just my point. Okay. So what do we do for these folks that changes their management? It turns out the blood pressure goal less than 130 is really good. So less than 140 really gets most of your ischemic strokes. Less than 130 adds a couple more percentages to your hemorrhagic strokes. So that's very useful knowledge. Obviously, stop smoking. Remember that there's a quit line. There are therapies. There's pills. Really, you guys have probably seen this many, many times. Really, people just have to really want to quit. And so first, just exploring that, like, hey, do you actually want to quit? And just getting them thinking about, oh, do I even want to do this, actually is the first step in working through that. Because if you can give them all the information in the world, if they don't realize they don't even want to quit, you're not going anywhere. And those motivators are always very, very personal. Plenty of people with multiple heart attacks don't quit smoking, right? As soon as granddaughter starts coughing from asthma, they quit. You just have to figure those things out. Obstructive sleep apnea. So this is a big thing that we've also don't think about. So it has about the same risk for stroke as smoking, also very treatable, and you have to look for it. Obviously, most people don't know they have it because they're asleep. You can screen for it by saying, do you wake feeling refreshed, do you have a sore throat, headaches, all that sort of stuff. Those are useful, but I would say anybody with a stroke, especially a lacunar stroke, should probably just be screened. And as our BMI start increasing, this is just going up. But it goes up with age anyway. Turns out, daily exercise, 20, 30 minutes a day, the kind of exercise where you can talk but not in full sentences, so not super rigorous, but something you're doing, that has about a 25 to 27% stroke reduction. So that's better than aspirin. That's better than a statin. That's better than pretty much almost any pill I can give you. So that's huge. And especially if you have people that are resistant to take medication, that they can do. Okay? And they can start with just walking around the block for 20 minutes as long as they're kind of working at it. The same thing with diet modification. So same thing with fruits and vegetables. So if an American diet all of a sudden comes to 5 to 8 servings of fruits and vegetables a day, they have that same risk reduction. That is not prospective controlled data. There's an exercise intervention that shows that. These are sort of population-based studies, except for this one. There's a Mediterranean diet. This is the only one that I know of that's actually an interventional thing. So the other ones we look at sort of population studies, right? We say this group exercises, this group doesn't, and this group doesn't get stroke, this group does, right? So that's the vast majority of data on diet and exercise. But a group out of Spain that did a multi-country, multi-continent study where they took people who were at risk for stroke, so 50 to 55 with diabetes but never had a stroke or heart attack, and they randomized them to just keep on eating what you're doing or to go to a Mediterranean diet that was either high in the fats were all coming from olive oil or coming from nuts as the categories. And you can imagine how hard it is to make sure people are eating what they're supposed to eat, right? So it's a pretty difficult study. But at the end of 5 years, they kind of looked at the data. And within 3 years, the stroke reduction between the two groups was dramatic. Again, we're talking like 25 to 30% stroke and heart attack reduction in the Mediterranean group alone. Which, if you think about the Mediterranean diet, it's actually not that hard. For most Americans, it's really just cutting out processed sort of donuts and things like that and red meat. And that's about it. So it's really not onerous at all. And it actually is about the only thing that I know that actually has prospective sort of interventional data like that, like a pill almost, right? And then you take along with that eating salmon once a week reduces your chance of dementia and cancer. I mean, the benefits from these things, right, are just far more reaching than stroke. Weight loss is interesting. So weight loss in isolation, it's failed really by itself to demonstrate really dramatic reduction in stroke. Because how do you account for the blood pressure reduction, the diabetes reduction, the daily exercise, all these other things that go into it. But it's obviously a good thing. Aspirin, I said, about 20% reduction. This is secondary prevention data. And statins, statins have been touted as a sort of like miracle drug. The data on them is not as miraculous as you would like. I don't know, did anybody realize there was so you guys know there was a recent guideline change in statins? Yeah. And did you guys know it's very controversial? So I was actually at a conference last spring, and they had like a debate about this. And on the panel was one of the people who wrote one of the most scathing criticism of it, she's very well respected. There was somebody who was on the committee, and then there was kind of somebody in between. And it was quite eye-opening. The data for primary prevention is basically almost nothing. It's about a 1% reduction in mortality for people who have risks over about 10 years. So their recommendations seem fairly heavy-handed for that. The other thing, too, is almost all of the statin trials were drug company sponsored. There's only been, I think, 2 that were not. And none of them really looked at side effects. And so, I don't know, I think the bottom line for us is if you've had vascular disease, you have risk factors, you should probably be on a statin. Whether it's high intensity, low intensity, I think is up for debate. And I also think if you have any side effects, it's probably not worth it. It doesn't hold a candle to diet and exercise. So if you can put a little extra on there, great, go for it. I'm not against them. I just think that there's this mentality in America to have a pill for things. And in that category of pills, I would not put statins real high. Now, there's some data about maybe acute management of ACS and and other things like that, fine. If you want to use a high intensity for short term, that's great. But clearly it increases your diabetes risk. Clearly people have muscle aches and fatigue on it, and there's a growing body of evidence of people with dementia on it. Well, I should say memory complaints, because when you stop it, it goes away. So pay attention for those things in your folks. There's also been various data back and forth. Again, unfortunately, it seems like how close you are to the drug companies about fall risk in elderly folks with statins as well. So, yes?
What are your thoughts on like dietary supplements like the omega fish oil?
Oh gosh, I wish they worked. I really wish they worked. So the omega-3 totally failed. Niacin totally failed. So it turns out that eating a fish is better than trying to squeeze what part of a fish into a pill. Big surprise. So, but that, and actually, ironically, the whole pot literature have created this new sort of idea around these things, and this is entourage idea. So the entourage idea is that, when we see things like niacin fail and fish oil fail and all these sorts of things, but diets high in those things seem to work, right? We kind of think, well, why is that? And what it is, the idea now is that, okay, omega-3 is probably good. Nobody doubts that, right? But why didn't it work? Well, there's probably a lot of other similar things in that fish that also really benefit you that you lose when you try and just focus on just the omega-3. And that's this idea that it's an entourage of other substances that are also probably beneficial. Or counteract something negative for whatever one little thing you failed on. So red wine failed too. I don't know if you guys know that. The University of Connecticut professor actually went to jail for that, for fabricating that data. So red wine is actually not helpful. Yeah, he's like $3 million lawsuit, and he's in jail.
So that's not part of the Mediterranean diet?
It's not part of the Mediterranean diet. And it's unfortunate. The problem with supplements in America is it's basically unregulated. So what's in a pill, what's on the label doesn't have to be in the pill. The pills don't have to be safe. So it's 1 in 5 that actually has the substance on the label that's actually in the pill on survey. And 1 in 3 has something that's harmful or prescription that's not on the label. And the number of intracranial hemorrhages I've seen from supplement use is pretty high. I did a research study in undergrad just looking at an energy supplement that had cyanide in it. So the point is you don't know what you're getting, you don't know if it's consistently in it, you don't know it's safe, and if it has a prescription, if it actually is shown to be useful as in terms of a drug, then it is regulated by the FDA. So if it is a medication, then it shouldn't even be in a supplement anyway. So there's really, I wish they worked, and I'm sure there's some that are very beneficial, because when you look at some of the data that's come out of other countries that actually do have regulations on these things, there clearly are benefits for some of these things. And I don't think it's, I think, aspirin's from willow bark. I mean, statins are in red yeast rice. I mean, there clearly are very useful substances. But if you really want them in a controlled, safe manner, the American supplement industry is now multi-billion-dollar, and it's just not going to happen here, unfortunately, to be safe. Yeah, boy, a lot of the Chinese supplements that people get online destroy their kidneys. It's just it's just sad. And I think that some of that's our fault, right? I mean, people are distrustful of the medical system for various reasons, or can't afford it, but then end up paying more for supplements. So. My general take on it is, if you really love them and you want to use them, that's great. Let's talk about it. Let's go through it. Let's make sure I'm doing my best I can to avoid interactions and other things like that. But in the end, I still can't tell you that what you're taking is actually, what you think you're taking is what's actually in there, unfortunately. Now, that's different than vitamins and minerals. Those are regulated. So carotid disease, we usually do treat pretty aggressively and treat early. Medical management for carotid disease is actually pretty good for stroke risk reduction, so not everybody needs surgery. So if you're not a surgical candidate, because you don't have lungs that work anymore from COPD, maybe you don't need surgery. Medical management's pretty good, but still intervention is usually a little bit better, so we try to do that. Atrial fibrillation, we usually anticoagulate pretty quickly. The original sort of warfarin versus aspirin for recurrent stroke with atrial fibrillation saw a little bit increased hemorrhage rate in the first 2 weeks with starting anticoagulation after a stroke, so we usually do wait a couple weeks. That data is sort of with the caveat those are usually bigger, badder strokes, so I usually do start a little bit earlier than that. But people who have atrial fibrillation-related strokes usually do start anticoagulation sooner. And now we have 3 new anticoagulants that, especially for folks who are not going to get their INR checked, are pretty useful, I think. The newest one currently still has, unless you're Medicare, Medicaid, has $20 a life for life copay, $20 a month copay. So that's good. And again, the loop recorders kind of fall into that sort of idea as well. So interventions, what do we do that actually helps? So this is a very nice study. It was the Express study. It was out of the UK. I'm pretty sure it was all UK-based clinics and ERs. And the idea was they looked for several years at just what their standard of care was. And then they looked for several more years after introducing these rapid TIA evaluation clinics and just say, well, we can do it quickly. Did it actually help? And so what it was is they went from being seen in from 3 or more days to 1 day after a TIA, or getting treatment in 20 plus days, 20 on average, but a lot more after that, to less than 1 day. And what did they do in stroke? Well, the 90-day stroke reduction went from 10% to 2%. Then a 90% stroke reduction, and this held true at a year. So nobody can say it was the blood pressure management. The minority were anticoagulation and carotid stenosis. It was actually a pretty small minority. So this is like blood pressure, diabetes, all that sort of stuff, probably mostly blood pressure management, exercise, that sort of stuff. So it does work, and it works really well. We don't really have anything more effective than that list I gave you. That's about the best you can do for the vast majority of people. One of the interesting things about stroke is it's about, in America, probably about 60-80% preventable, the majority of the strokes we see. And in neurology, there's nothing else like that, right? I can't reduce the chance of Parkinson's, right? I can't really reduce your chances of dementia too much. But stroke is very preventable. One interesting thing about that data is that's the same whether you're in West Africa. So if you take something very cheap like hydrochlorothiazide to countries where people tend to have blood pressure problems, India, African countries, you can also see a dramatic reduction in stroke by just giving people blood pressure control. It's very interesting. It's been done in like rural India and things like that. So it can be done. So some things that mimic TIA, migraine is probably one of the biggest ones. Vertigo from vestibular stuff. Syncope is big. And so the reason I bring this list up is whenever it's TIA, I also think of what are the other things we could mimic that actually you really worry about. You worry about stroke, right? But it's migraine, okay. So you call it TIA, it's migraine. What real harm are you doing, right? Probably not much. But if you don't get a good exam and it was syncope, that's kind of important. You probably want to know about that, right? Same with seizures, same with hypoglycemia. Stress, anxiety, okay, well, just make sure your patients are safe and doing everything you can for them. But, some of these are diagnoses of exclusion. Some of these things you have to really kind of keep in the back of your mind. And generally, an eyewitness account or a good history will help tease them apart. So this is our pathway. I'll go through it, the top part here a little bit bigger so you can see it better. So this is how we do our TIA clinic. So usually, generally, people come into the ED. They can come from clinic as well. And we do the ABCD2. We do a CT-CTA because they're already in the CT scanner. If they don't have a contrast allergy and their kidneys are fine, we just do it. The yield is higher, and we end up, I think as vascular neurologists, I've been falsely reassured so many times with ultrasounds. And the opposite of that is, oh, that looks bad, we should take them to carotid endarterectomy, and then, oh, look, it actually was like 50% stenotic. It didn't cause it. And now in the monitoring of atrial fibrillation, and they get unnecessary surgery. So CTA is just where we start. That's our preference. If you look globally, the preference is by far carotid ultrasound. But in America, people really prefer CTAs. Canada would be an ultrasound. So they usually call one of us, and then we decide high risk, low risk. This also has to do with further events, carotid stenosis, like I was talking about, that ABCD3. And so if it's low, then the patient's stable, we usually get the rest of it done as an outpatient. So things like echo, MRI, all that other stuff. Because you can draw the labs there. They're not going to come back right away, maybe not even fast enough to do anything. If not, you come in and we watch you. And we watch you pretty closely. And we watch you closely because if you're in that high-risk category, your symptoms resolve, we're going to give you TPA if you have a stroke, right? So we can intervene quickly. We can do, intervene on carotids quickly. We can anticoagulate you quickly, all that sort of stuff. And we do the rest of that in our workup. Now, if we find an MRI positive, we just call you a stroke. But in general, the risk management that I said for TIA is pretty much the same for acute stroke too. So outside of TPA. So that is what we do. So basically the big thing is we realized we in the vascular kind of neurologies, we just call it stroke. In fact, we're trying to move away from patients even using transient ischemic attack anymore because it seems to downplay it. And so we just say, you had a small stroke. That's just the way it was. You're lucky enough you got better, but you got a stroke. You know, don't kid yourself. This is time to actually start getting out and doing it. This is the time to quit smoking. And we feel like that's probably much more effective than saying, oh yeah, transient ischemic attack, right? It also helps because if somebody said, oh yeah, you know, every Christmas time I get tingling numbness in my right hand and face, or perioral numbness, yeah, that's the best one, perioral numbness and tingling every time Christmas rolls around, and it's a TIA. And you kind of have to set them, like, no, that's not. That's anxiety. Christmas is stressful. It's not a stroke. You did not have a stroke. That's useful to make those distinctions rather than sort of a garbage term of TIA, because that happens all the time. Or, yeah, you know, every once in a while I wake up with an arm that doesn't work. It's tingling and numb, and I'm a little confused. And by the way, it's been stereotyped for 3 years, and it's a TIA. Probably not. You're probably having seizures. And that's also a very good thing to kind of. So TIAs are usually not stereotypes, right? If you think about it, if you have a clock going up to your head, you ever see Price is Right Plinko, right? Why would it go to the exact same spot of the brain every time? It could, but it's not likely, right? And the big thing is, of course, we can reduce disability, we can reduce strokes. So I found this picture, I thought this was interesting. I've been reading about Ellensburg. It's been here for a long time, this town. Oh my gosh, you guys know the name? Where it came? But no, why it's called Ellensburg.
She was gonna, Ellen was gonna be the governor, and that's why the castle was built.
Yeah, it's a great story. It's a great story. I haven't seen this. Where is it from here? Oh, that, okay. I mean, I do have a phone, but I would appreciate it. I like the human touch. Okay, interesting. Pearl. Great. That's great.
Fourth and Pearl.
Yeah, so I think this is from like 1905, 1910 or so, because they have electricity, but not much else. Great. What are your questions?
So cost.
Yeah.
You did mention the MRI does cost more than CT, but a lot of that, you didn't say what the cost of that implantable thing is.
So out of pocket would be 5 or 6,
And so
but Medicare and Medicaid's been covering it.
that's part of the problem. You don't want cost to be an issue, but it is an issue in this country. And
Absolutely.
sometimes when we keep talking like it's not an issue, we're just going to do these things that seem to work the best, there has to be a balance somehow. And
Absolutely.
I don't know how that's going to get played out in this country, but
I think we won't know for a very long time.
Our
But
tendency is to just throw more technology at things and it works, but
yeah.
there has to be a balance somehow.
And I think that's where especially some of the data from Canada really helps, because they have a similar sort of demographic, they have a similar sort of rurality, more so.
Ultrasound versus
Yeah,
CTA.
and so they ultrasound. They do a CT and ultrasound, because why would they do all this other stuff if it doesn't dramatically change management? And then they say to themselves, okay, well, you are a 60-year-old diabetic smoker with a family history of vascular disease. Maybe you need a CTA then, because maybe you're at higher risk for that sort of stuff. Or genetically, there's certain groups from Asia and other stuff that also have more vascular risk. So you can stratify that way. I think that's a very reasonable thing. The big thing I caution with costs here is transport to us is enormous, right? So, and it's been skyrocketing. So in Utah, what used to be a $10,000 transfer is now $30,000. I mean, it's just skyrocketing, right? And so I think that's another really big thing. Are these people who have a higher TIA score, are we going to transport them or not over to us for urgent evaluation and management? And I think that just needs to be an ongoing discussion as well as all the rest of it. And I think that's the most important thing with all this is you just try and figure out, who is this person? How does it impact their life? What are we going to do, right? And you guys have plenty of people that are older here too, right? And so I think in the end, how it's going to affect management is the real question, right? Because if you say, well, I'll call this a stroke, let's give them aspirin and statin and diet, exercise, all that stuff. We're going to do that regardless of the results. And then we'll look to see if they have AFib. Do they need to come over to see us for that? We're not going to change their management with the MRI. You know what I mean? No. So even though that might be a higher risk patient, I would say you keep them, put them on telemetry, and then go from there. Do the rest of it.
Yeah, it seems like if MRI is getting used more and more and more.
Yeah.
I just remember my brother-in-law had a stroke, and I went over to see him in the ICU. I was over in the Seattle area somewhere, and it's like, you just look at the technology they were throwing at him, and he ended up dying because it was a really bad stroke. But he had like 2 MRIs in the ER. While he was kind of still in the ER and stuff. We were just looking for transitions and changes and stuff. I think if we're going to use MRIs a lot more, which seems to be the tendency in medicine, how come we can't get the cost of the machines down?
I wish I could answer that.
I mean, they're getting used more.
Yeah.
And most technology, your computers, your TVs,
Yeah.
they get cheaper, but nothing associated with medicine is cheap.
Well, I think that's not just I think it's a demand and resource sort of thing. I think, unfortunately, I don't know if you saw this, there was a report that was commissioned by the American Medical Association that was released last year, where they looked at the rising cost of healthcare just in the last 10 years. So basically since the late 90s, from after the 90s, early 2000s on. Because one of the things has been this inflation, right? So people blame this sort of overall sort of things and point fingers and stuff. But one of the big drivers has been the bigger hospital groups just simply charging more money. And so I think that that's one of the problems, is that we have this system where nobody really knows how much things cost. It's always a negotiation with insurance companies. So it's a moving target. Nobody knows. And the people driving the costs are not necessarily people that have the patient's best interest in mind. And so I have no idea how to discuss the cost of an MRI without taking into context the whole system. Why some person's aspirin in the hospital is $400 and the other one is $20, when in reality that pill is less than a penny probably, right? And you have to compensate for lost costs and all these other things. Sure, I understand that, but it's a very difficult situation. So I wish I did. I can tell you that the MRI technology has not significantly changed that much in the last 10 years. We have bigger magnets, but in terms of the superconductors needed to cool everything down, it's not dramatically different. So I think if we did have much higher efficiency in the superconductor realm, we probably would see faster, smaller, more affordable MRIs. But the upkeep on them is just dramatic. I mean, a lot of, especially the bigger ones, the liquid oxygen has to be cooled with liquid nitrogen, which is not exactly a easy setup. So I think that's a big part of it. Yeah, if you don't need an emergency MRI in Canada, it's like 3 months.
Yeah.
So
in addition to aspirin, will Plavix include outcome of the
So it's a great question. So are you familiar with the CHANCE study from China? So out of Beijing, there was a study released almost a year ago now, where they randomized people to aspirin and Plavix, and the Plavix was for 21 days. And that was low risk stroke, like minor stroke and TIA. And they found a statistic that it was beneficial. It was beneficial. Yeah, it did reduce that without a significant hemorrhage risk. There's currently a trial here called the POINT trial that's mimicking the same thing as 3 months. So there probably is a benefit for some of the higher risk folks. I would say somebody already on aspirin, they probably would do antiplatelet therapy. I wouldn't be surprised if at the next stroke conference in February, we won't have the POINT data. They're just now doing their interim summary this month, or maybe it was last month. So we won't have that data, but that is sort of the trend. The big thing is everybody kind of feels very comfortable, and the bleeding risk is not too bad if you do it for a short amount of time. But clearly, at a year or so, the bleeding risk of antiplatelet therapy is almost the same as warfarin plus aspirin. So I think that what happens a lot is I see somebody get a stent, and then they're still on aspirin Plavix 3 years later. You know, and that same person maybe gets a COPD exacerbation and gets a little bit of steroids. Guess what? They have a GI bleed. You know, I mean, and so I see a lot of harm. I mean, I'm biased, right? Because I see the hemorrhages. But I say, why are you even on dual antiplatelet therapy? Oh, somebody thought it was a good idea. Okay, but there's data on this. Same with aspirin and warfarin. So there's this notion of failure of aspirin and warfarin. Aspirin doesn't cure your strokes. Warfarin doesn't cure your strokes. You still have strokes on them. So I just think it's a fallacy.
So when you're doing more stenting now, interventions.
You know, stenting versus CEA really depends on the center you're at and sort of the patient you're dealing with. The data favors older folks should have a CEA, so over the age of 70. Younger it's equivalent. It has equipoise. But if you've got a tremendous stenter and so somebody who doesn't do vascular surgery very often, I'd probably go, you know what I mean? So that's how I balance it.
So you're not stenting above the carotid?
Above the bifurcation? What is the ICA?
Okay.
The proximal ICA.
Okay.
Yeah. But intracranially stenting is pretty rare.
Okay. And then
Yeah.
are you using Plavix with the same guidelines as the cardiologists use?
For the stents? Yeah.
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 So,
Which also varies highly between countries, turns out. So a lot of countries only do weeks of both for an acute stent, whereas we do months.
in this country, is it 6 or?
So the minimum is 3 that I've seen, yeah. A lot of the interventional trials in Europe, we did 4 to 6 weeks of dual antiplatelet therapy for a fresh stent. So again, it's probably safe for a couple months, so that's probably fine. Yeah.
My brother had severe strokes at 58. His arteries were too small to stent, and he stroked again while they attempted to at Mason.
I'm sorry.
So it's 4 years, and he's still on Plavix. I mean, what?
Yeah, probably not the. I mean, I'm giving you sort of a generalization of therapies. Some people, we do feel like they have such active lesions that we'd use both, but there are other things. So you can check whether Plavix has the advantage. You can check how active it is, where aspirin you can't. So you could just check it. Maybe the Plavix actually not doing anything. And there's a newer medication called cilostazol that we've been using for folks in similar situations. So actually a nice double-blind randomized trial out of Japan for that sort of situation, reduced stroke. So that's somebody we should maybe see in clinic.
I was going to say maybe he should have a follow-up.
This is a good segue. Thank you.